a slight changing schedule because we have 6 talks left, and we would like to invite Professor Feifei Zhou to give his talk, and then we'll take a coffee break. And Feifei is going to share his experience treating cervical deformity, including both craniocervical junction and subaxial deformity.
Sorry, waste your time. So this is my second topic to follow up the presentation yesterday by Professor Sun. So today I will introduce precisely about the correction surgery for cervical, especially in craniovertebral deformity. So I have nothing to disclose. So the craniovertebral junction, the CVJ region, defined as the region extending from the occiput to the C2 vertebra, constitute the traditional zone between the skull and the spine. The craniovertebral junction deformities include all of these kind of deformities, such as basilar invagination, odontoid dysplasia, and so on. So for patients with cervical scoliosis involving this region, cases are rare and pose significant surgical challenges. However, these patients typically present with 3 major characteristics. The first one is as the CVJ forms the anatomical foundation of the skull. Even mild coronal malalignment may result in pronounced craniofacial asymmetry. And number 2, atlantoaxial instability or dislocation is commonly associated and may lead to progressive neurological deficit. If left untreated, the result is terrible. And the last one, the vertebral artery anomalies are frequently observed in this region and subsequently increase the surgical risk during the correction procedure. So for congenital cervical scoliosis at this region, international treatment strategies have evolved through 3 distinct phases. Phase 1 is the local cervical fusion was performed to stabilize the deformity. And phase 2 is the resection of the convex side structures within the CVJ region, such as hemivertebral resection. And the last phrase, that is the distraction on the concave side that try to employ to restore coronal balance and representing to shift toward anatomical alignment with a minimal procedure. So this previous literature on this topic is extremely limited. So we have just defined only 5 relevant studies have been identified and related to this topic. So the earliest of which was published in 1986 by Professor Duboset, who is a very famous professor and passed away in May this year. So I just show my great respect to this great doctor to do a lot of work on this subject. So you can see in phase 1, the primarily include the first 2 studies during which the surgical strategies focus on in situ fixation and the cervical fusion to halt the progression of the scoliosis. So the first one I mentioned that published by Professor Duboset in 1986 was reviewed 17 cases of torticollis in children caused by congenital anomalies of the atlas. Among these 17 cases, 10 patients receiving bracing treatment, but showed no improvement. Another 7 patients underwent surgical intervention between the year of 1975 to 1983. All of them achieved successful fusion. But the surgical method described involved the halo cast correction followed by posterior fusion. The surgical strategy varied depending on the deformity pattern. For isolated C1 hemivertebra, C0 to C2 fusion was performed. In cases with associated deformities, C0 to C1 fusion was combined with a short segment fusion of the subaxial cervical spine as needed. However, it is important to note that cervical fusion alone cannot correct pre-existing deformities. And in phase 2, marked a critical stage in the evolution of surgical treatment. During this period, spine surgeons worldwide began utilizing combined anterior and posterior approaches to resect the convex side vertebrae responsible for the cervical scoliosis. So these procedures were performed with careful protection of the vertebral artery, nerve root, and spinal cord, aiming to restore cervical alignment and prevent further progression of the deformity. In 2005, Dr. Roof firstly reported the surgical resection of the cervical hemivertebrae. The study involved 3 children with torticollis caused by subaxial cervical hemivertebra. All of them underwent successful resection procedures. These operations resulted in significant correction of cervical deformity. So these 3 landmark cases represented a breakthrough in the surgical management to the treatment of the congenital cervical scoliosis. So Dr. Roof and Dr. Harms just pioneered the concept of the hemipterygium resection in cervical spine. And a decade later, Dr. Ruff extended his experience in cervical vertebral resection to the craniovertebral junction region. In 2015, he was the first one to report a successful case of CVJ hemivertebral resection in the Journal of Spine, marking another significant milestone in the surgical management of the complex cervical deformities. Let's look at this case. This case described a 42-year-old female who initially presented with persistent right C2 radicular pain. The patient underwent C1-2 decompression infusion, which provided temporary symptom relief. The symptom about pain and torticollis recurred 15 months post-operatively. In response, the doctor performed a resection of C2 wedge-shaped vertebra, addressing the underlying structural cause of the deformity and the symptoms recurrence. So Dr. Rolf performed a 2-stage hemivertebral resection of C2. In stage 1, a transoral approach was used to resect the right hemivertebra of C2, providing anterior release and partial deformity correction. And followed by the stage 2, 7 days later, a posterior approach was performed to complete the resection and achieve spinal stabilization and fusion. So these staged strategy allowed for controlled correction while minimizing the risk of neurovascular complications in this anatomical complex region. In 2022, our hospital, Professor Sun, reported a novel surgical technique for correcting cervical scoliosis using the concave side distraction mentioned by himself yesterday, and compared these outcomes with those traditional convex side resection. So this publication marked the formal beginning of the 3rd stage in the surgical management of congenital cervical scoliosis. So the detail of the procedure was described by Professor Sun yesterday. So we just go straightly to the result. We can see the comparison between the distraction method and the resection method. So in demographic and operative data, group distraction named Group D had less operation time per vertebra and less blood loss per vertebra than the group of resection. The other data showed no statistical difference between the 2 groups. Meanwhile, there was no statistical difference in correction rate of each radiological parameters between the 2 groups. And in resection group, the mean structural cup angle before the surgery was nearly 30 degrees, and got the well correction turned to 5.3 degree after surgery. So the average correction rate was 81%. And in group distraction, the mean structural cup before the surgery was 33.7 degree, and after the surgery, the deformity corrected to on average 12 degree, and the average correction rate was 66%. So to elucidate the clinical characteristics, surgical strategy, and post-outcome of patient with cervical scoliosis at the CVJ region, we did another special research on just a specific region. So this reproductive study was conducted on patients who underwent surgical treatment in our hospital. The CCS at the CVJ region is an because the previous study was extremely rare, so we applied strict inclusion and exclusion criteria, including the cases of ocular torticollis, muscular torticollis, and other causes to the health. So finally, a total of 27 surgical patients were enrolled in this study. So based on the deformity characteristics and the corresponding surgical strategies, the 27 patients were categorized into two groups. So group A means cervical scoliosis involving in CVJ region only without subaxial cervical scoliosis. And group B means cervical scoliosis involving in the cervical region combined with the subaxial cervical scoliosis. And the definition of subaxial cervical scoliosis was a structural curve with a compound angle more than 10 degrees with a responsible segment isolated between C3 to T1. So these classifications highlight the difference in deformity distribution and serve as a foundation for the specific surgical planning. So this table summarizes the overall characteristics of the 27 patients in this study. Group A consisted of 10 patients and Group B included 17 patients. The mean operative time was 473 minutes with an average intraoperative blood loss was 336 milliliters. The median follow-up duration was 3 years. Although the mean age of the surgery was 7.8 years, the patient had already experienced an average of 6 years of torticollis symptoms prior to the surgery. So we can see in Group A, the 10 patients only have the scoliosis within the CVJ region. 2 patients underwent convex side resection, while the remaining 8 patients were treated with concave side distraction method. The majority 9 out of 10 in this series of patients, Group A, were managed using a posterior-only approach. Only 1 patient required an anterior transoral lease, followed by the posterior distraction for the deformity correction. And in Group B, 17 cases combined with scoliosis in CVJ region and in subaxial cervical spine. The vast majority of these patients underwent combined distraction procedures using a anterior-posterior approach. This approach was primarily determined by the need for anterior release and distraction in the subaxial cervical spine to achieve adequate deformity correction. Moreover, the patient with CVJ deformities requiring anterior release. So the first anterior release can address both the CVJ region and the lower cervical segment. That procedure about the first phase of anterior release can make it safer and more effective in the next posterior distraction in the next stage. So to thoroughly characterize the deformity patterns in this red cohort, we did a comprehensive set of sagittal and coronal radiographic parameters collection, such as like this, all of these parameters, including local cervical alignment, global coronal, and sagittal alignment parameters. So the structural curve angle SCA showed significant correlation with the head tilt HS and head neck tilt NT, and the clavicle angle CA, indicating a consistent pattern of head and shoulder alignment. So in contrast, thoracolumbar or global spinal parameters such as the thoracic curve angle TCA, lumbar curve angle LCA, and coronal balance distance CBD were generally uncorrelated with the head and shoulder measures. This discrepancy may be explained by the predominantly upper cervical location of the deformity in this cohort, where the shorter mechanical level arm likely limit the influence of the upper cervical deformity on overall spinal alignment in both coronal and sagittal planes. So this is typical case, a 6-year-old boy with hypoplasia of the right C1 lateral mass, leading to the craniovertebral junction deformity. This boy underwent CVJ convex site resection with the assistance of 3D point and an anatomical model to precise surgical planning and during the surgery. So we can see the result after the surgery. Structural curve angle improved significantly and achieving excellent correction of the upper cervical deformity. Another 10-year-old boy diagnosed with hypoplasia of the left C1 lateral mass resulting in upper cervical deformity. He underwent craniovertebral junction concave site distraction with preoperative the 3D planning device to guide the distraction at the level of C0 to C2 facet joint. So following the surgery, we can also see the great improvement from 25 degree to 6 degree after the surgery. So in summary of the summary A, the isolated craniovertebral junction deformity, we can choose both resection and distraction method. So the posterior distraction not only achieve deformity correction, but also facilitate atlantoaxial realignment. So when the posterior release is inadequate, such as in case of vertebral artery anomalies or anterior bony fusion, of course, at this time, anterior release is required at the first. So the anterior release approach includes transoral and submandibular approach, which means transoral may have the higher surgical risk and submandibular approach had the lower surgical risk. And if we can see in group B, the deformity both in CVJ region and subaxial cervical spine. This is an 8-year-old girl with a C2 wedge-shaped vertebra and the hypoplasia of the left C1 lateral mass and the C4 hemivertebra. So this girl underwent combined concave site distraction in these two regions. So distraction at the right occipital condyle at C2 and anterior of C5 to 6. After the surgery, you can see the structural curve angle improved significantly from 28.6 to 3.3. So in summary of the group B, the complex deformity combined distraction when anterior release at the CVJ region is required, two separate incisions were necessary. So transmandibular approach of the CVJ axis, that's our first choice, and standard anterior cervical approach for the lower cervical segment, that's later on. Anterior column distraction and fixation at the lower cervical spine plays a crucial role in maintaining the spinal stability and promoting osseous fusion and facilitating postoperative recovery. So you can see the patient satisfaction after all of this surgery. We can see most of the patient, 23 out of 27 have the satisfied and very satisfied effect. How about the complications? There's no severe injuries occurred, which means a spinal cord, a nerve root, or vertebral artery injury during the surgery. And there were 5 patients suffered C5 nerve palsy, and all these 5 patients were from group B. That means complex deformity in both upper and lower cervical spine. Each of these patients had undergone distraction at a segment adjacent to the C5 nerve root, and all of these patients got recovered after 6 months. So there are 4 patients have the CSF leakage, and 1 with delayed wound healing, and 1 patient had temporal bone fracture. And we have 2 patients have the internal fixation displacement. All of these patients involve severe deformity, which means the column go more than 15.5 degrees, and the dysplastic facet requiring bigger implant placed at an inclined angle, so potentially leading to a localized stress concentration at the concave side of this region. However, both patients remained asymptomatic and were managed conservatively. And in avoid of vertebral artery injury, try to reducing the intraoperative operative risk, operating time, and blood loss. Enable preset planning of the distraction height based on the chronal imbalance to achieve effective realignment, even in anatomically complex cases, and restoring cervical length without resection, which helps prevent further shortening of the neck and deterioration. So Professor Sun mentioned yesterday about the eccentric cranial traction. The application of the concave side distraction, that may be the first step is the eccentric cranial traction, which means we can create a distractible gap between the vertebrae. So we started this traction since 2019. So as illustrated in the figure A shows a superior view, and picture B shows a lateral view of the head during the traction. So you can see the arrow 1 indicate the eccentric traction weight applied on the concave side, and arrow 2 indicate the axial, means the central traction weight applied vertically. This method allows for gradual soft tissue release and prepares the cervical spine for controlled traction. And we applied axial traction to both the central point and the eccentric set of the cranial arc. Traction weight were applied along the coronal mid-axis, beginning with the central traction equivalent to 1 out of 10 of the patient's body weight. Eccentric traction was subsequently applied to the concave side, starting with a weight equivalent to 1 out of 20 of the patient's body weight. So the patient underwent this kind of traction in a supine position for at least 20 hours per day. Besides the cervical X-ray were obtained every other day to monitor alignment changes between the facial midline and the cervical spine axis, and the traction weight were adjusted as needed. And the aim of eccentric cranial traction is to achieve the preoperative soft tissue release of the muscle and ligament around this region, while effectively correcting the chronal imbalance between the cervical spine and the cranial axis. So the intrinsic cranial traction facilitates subsequent concave side distraction, making our procedure more controlled and technically feasible. And you can see the cosmetic correction rate was calculated by this formula. And you can see this is the cosmetic rate after the first day, the last day, and the post-operation rate, and during the follow-up. So the second step involves selecting appropriate spaces and fixation. So as mentioned by Professor Sun yesterday, before 2019, PKH with their uniform size often inappropriate to match these irregular space. So we just came to a 3D point individually shaped divisor after the year of 2019. So in general, the cervical congenital scoliosis, as this CVD region, represent a very complex deformity and rare reference to follow. So the implication, the implementation of the individual surgical strategy has demonstrated that favorite cervical outcome, no matter the chronal balance and the psychological well-being to each child. So as for the congenital cervical scoliosis, Professor Sun and I just present in these 2 days, you can see just we started from the 2009. So I am a junior doctor to assist Professor Sun, and 16 years later, I just performed this kind of surgery by myself, and we just do a very tough work during the first few years. We have to shape the cage and to put in the screws freehand, and this time, just we can use a navigation and a 3D point spacer. So we have done the PUTH classification. We have found the 2 very effective ways to crack this kind of deformity. And we set up the CROCS cohort I mentioned the day before yesterday. And we established the MDT team, and we have the 3D point spacer and the navigation system. What I'm doing in the future is that we try to find the mechanism of this very rare congenital deformity, and we try to make some change and make the surgery much safer. And we also to find out the result within the long-term follow-up, and try to make the consensus between the different specialties in the MDT team. Maybe in future, AI may help us to find out the way before surgery and during the surgery, and even the follow-up. So maybe thank you again for inviting us today this year. So we hope to see you again. And at final, we warm to welcome all of you to join the CSR's AP meeting next year in Shanghai, which will held in March next year. So at the chairman of the SEL, so on behalf of our chairman, Professor Shen Hongxing, to invite all of you to join us. Thank you for your attention.
Feifei, great talk. And I have 2 questions for you. One is that on one slide, you showed the vertebral artery dominance. I think it's actually the right side dominant is the majority of the cases, which, usually we think is the left dominance, about half the patients, and then, half of them are right dominant, half is co-dominant. Any comments on why the discrepancy in these patients? Is there a propensity for right side dominance? That's one. And then the second question is that, you said the 2 cages backed out. I'm just wondering, now with the 3D printing technology, is there any plan to kind of integrate, print integrated screws so that you can, lodge the cage in there while it's fusing? Then you essentially can eliminate or significantly reduce the risk. So those are 2 questions.
Oh, okay. Thank you. The first question, we just did the research and published in Spine that the anomaly about vertebral artery in this kind of deformity, the rate was very high. More than 50% of the patient have the anomaly of the vertebral artery. So because we have to the angiography of the artery before the surgery for each patient, so we can see whether there's anomaly before the surgery. So I think you mean the left or right dominant. In our study, in the deformity cohort, it's half and half. Not for our normal people, there's a discrepancy between that. So as for the, you mentioned and your comments that what we do right now, that not only we just set up a 3D point individually spacer, we just design some screws within the spacer and can lock within the facet or even some kind of the skull to help us. Yeah, thank you.
The concept of the distraction and holding that space open with a cage is, I think, relatively new to me in the cervical spine. And so I wanted to ask, technically, it sounds like you went from PEEK to 3D printed cages. First question is, for those of us that do not have access to these custom 3D printed cages, what do you think the best alternative cage type would be, something off the shelf that could be used? Could you use like an ACDF, small ACDF cage? Could you use a really small harms cage, or what other options are there for us that don't have this capability?
Yes. So in the early stage of we just perform this kind of surgery, we have no 3D point cage. We just use the normal cage used in ACDF. But a lot of these patients in children, the size were very small. So you have to shape, allograft in China was not allowed. So we can just use a PEEK cage and shape it during the surgery by ourselves. So it's very hard to have a material that can create to fit the space during the surgery.
So yeah, for those of us who have, say, tricortical iliac crest, would that be suitable? Or is that not rigid enough, or do you worry about that graft subsiding?
We do not use iliac crest, but I think it can be used, of course. But compared to the cage, whatever the PEEK or 3D point metal material, I think the strength of iliac crest was not enough. You have to rely more on your internal fixation.
So I think the customized 3D printed cages spacers is designed on a computer and printed by company. But I have seen exhibitors outside here, and they presented just regular titanium cages. So if you don't have these customized 3D printed, I think you can just use the regular cages, but you just need to burn it, reshape it. But at the beginning, we don't have that, so we just had this. Then nowadays in China, we have similar regular cages. Then you can just trim it, but it just you need lots of time on the table to shade, and all the the reticles from that will contaminate the table. So we have to set up another small trolley to do that. But I just don't know whether if you in US it's off-label use or not. But in China, if you can do it, because it's in register in Chinese, they just call it interbody spacer. So any part between the vertebra will be okay. Yeah, and also the advantage of the 3D printed porous metal spacer, you don't need to put too much bone graft in that. You just put it in and maybe get some MDP to surround it, and then maybe some allograft. That'd be okay.
Yeah, thank you for your talk, both yesterday and today. Creative, very artistic. My question was, and I'm sorry if you showed it on the slides, but the steps or algorithm and the distraction of the concave side, do you always go posterior first or majority of the time go anterior first? I know it's very case dependent.
Okay, thank you for your question. I think the first step is to just to test the rigid degree of the patient, because in some patient it's very flexible. You can just adjust the scoliosis to the normal position, and you know that is very flexible. And in some children, they are very rigid, and it's very hard to make it to the normal position. And we will put them to the eccentric cranial traction, and to create the space between the skull and the upper cervical region. And we just find out what the result after the traction. Or very flexible patient, we just go posterior first, and then it's make the surgery much easier. You do not need the anterior release at the first time.
So if rigid, go anterior first.
Yeah. Oh, yes. So, Dr. Praven, you mean the vertebral artery may avoid the correction?
You get some of these congenital, and then it's basically, that's a hemivertebra, but the hemivertebra can also sometimes involve the foramen transversarium. That can also be part of the hemivertebra. Like it has an extra foramen transversarium on one side, it doesn't have it on the other side. So what do? Do you ever release the vertebral artery in the foramen transversarium in any of these cases, or you don't have to do that?
We just need to release. Okay, Professor Sun.
So at the early stage, we don't have a microscope. We just use the loop to do that, and that's just minimal in relation. Now, nowadays, we have a very good microscope that can see everything. So we don't need to expose the vertebral artery, but during the surgery, we can see the pulse with the surrounding soft tissues. Then we just protect it with a pan field. Then just do expose the entry point for that, for the schools, and also to discredit space. So no need to expose the vertebral artery. But in our case, maybe have a 1 or 2 suspected vertebral artery injury, because during that exposure, it just had the fresh blood came out. We just use the sponging to push down. Then it stopped. So maybe it's a tiny hole around that, but it stops very quickly. So nothing serious.
So some of these you did the resection, right, of the concave, convex side. Yeah. In those cases, do some of this include the transversarium where the vertebral artery goes?
Yeah.
So you have to release it and resect.
You have to release it. It's really hard.
Yeah.
Nobody.
All right. If there's no other questions, we'll take a 15-minute break and then come back. Yeah. Good job.